Hello everyone. Let's see an important chapter of oral surgery today, disimpaction. We will be covering it in different parts. In this part, let's do the basics and definitions. So, what is an impacted tooth? So, an impacted tooth is the one which is unable to fully erupt to its normal functional occlusion or location by its expected age of eruption because it is blocked by overlying soft tissue, bone, or another tooth. So, we can break this definition into different parts. First is what is happening, what is the problem? The tooth is not able to fully erupt to its normal functional occlusion. Then, till when we will consider it a problem? If this tooth is not erupting to its normal occlusion by an expected age of eruption. Why it is not erupting? Because it is blocked. How? Because there is an overlying soft tissue, or there is bone present, or there is another tooth which is not letting the impacted tooth to erupt. So, which are the most commonly impacted tooth? They are mandibular third molar, followed by the maxillary third molar, maxillary canine, and mandibular premolar. There are various theories of impaction. For example, first is the orthodontic theory, which says that the growth of jaw and teeth is in forward direction. So, any interference in the growth pattern will cause impaction. Why? Because smaller jaw will lead to smaller space, which will lead to impaction. Second is the Nodine phylogenetic theory. It says that modern food habits lead to lesser forceful mastication. So, there is less stimulation of jaw growth, which uses the disuse theory. So, less jaw growth, less space, and again, it can lead to impactions. Then there can be Mendelian theory, which says that heredity is responsible, and fourth is endocrine theory, fifth is the pathologic theory. For example, if there is a cyst, for example, if there is a around third molar, there is a cyst present, it can lead to obstruction of the eruption of third molar. Now, the etiology. What can be causes of impaction? Let's see. There can be two major causes. First is local cause, second is the systemic cause. So, what can be the local cause? There is irregularity in the position, or there can be pressure from adjacent tooth. The adjacent tooth is not letting that tooth to erupt to its normal occlusal position. Second, the density of the surrounding bone or the overlying bone is so much that the tooth is not able to erupt. In this, we have to understand what is the difference between an impacted tooth and an embedded tooth. In an impacted tooth, the eruption forces are normal. The tooth is getting the normal eruption forces, but there is something which is blocking, which is obstructing the tooth to erupt. But in embedded tooth, the eruption forces are lesser, or lesser than which are needed. So, in impacted tooth, the main problem is it is obstructed by it can be either bone or any soft tissue. If there's localized chronic inflammation, then also there will be increased density of the overlying mucous membrane. Then there can be lack of space. For example, if there is an underdeveloped jaw, or there is crowding or presence of supernumerary teeth, these all can lead to lack of space. So the tooth does not has a space to erupt. So it will remain impacted. It will not reach to its normal location where it had to reach. There can be ankylosis of primary or permanent teeth, which can lead to that it does not reach to its occlusal plane. Then non-absorbing alveolar bone. There can be obstruction for eruption. For example, there can be condensing osteitis, or there is a soft or hard tissue pathology. For example, there can be cyst, odontome, or any tumor, or there is already the deciduous teeth is retained. So if the space is already filled by retained deciduous teeth, obviously the permanent tooth can't come to that to its normal position. Then dilaceration, that is curved root or crown. Then ectopic position of tooth bud, that the tooth bud was present so deeply in the bone that it is not able to erupt to its normal position. Then there can be infraocclusion due to arrested eruption. That is, the tooth erupted initially, but it didn't reach to that occlusal plane where it had to reach. So these all were the local causes. Now let's see the systemic causes. So systemic causes can be general, prenatal, hereditary causes. Second can be postnatal, that is affecting the development of child. For example, rickets, anemia, and congenital syphilis. Then malnutrition. Then there are many hereditary linked disorders, for example, cleidocranial dysplasia, trichocolon syndrome, and osteopetrosis, Gardner syndrome. So, the multiple impactor teeth are usually associated with syndromic patients. Now, let's see what are the indications for removal of such impactor teeth. Why will we disimpact the teeth? For example, if there's any infection in that teeth, or there is periodontal disease, or if there's external resorption of second molars, or buccoverted impacted molar, that is, the tooth is outside buccally placed and it is there is an increased cheek injury. In that case, we have to remove the impactor tooth. Then, prior to orthognathic surgery, if there's fracture of mandible, there's atypical pain, unrestorable caries, dentiger cyst. In these cases, we have to remove the tooth. But there are some cases in which we cannot remove the tooth, or we will not remove the tooth. For example, if that impacted tooth is likely to erupt successfully and function in the functional role in the dentition, that in some time, or in we can see that in this amount of time this tooth can erupt to its normal physiologic position, then we will not extract it. Then partially impacted tooth, they can be used as an abutment in FPD. Then medically compromised patient, if there's deeply impacted tooth with no history of pathology, and if it is close to vital structures, for example, maxillary sinus. So this was all for this video. If you found this video helpful, like and subscribe for more.